एनलार्ज कर रहे हैं दिवाशिव।
सुना था डॉक्टर्स भगवान का रूप होते हैं, पर आज ऐसा लगता है कि कोरोना वायरस से लड़ने की इस चुनौती की घड़ियों में भगवान ने ही डॉक्टर्स का रूप ले लिया।
Thank you so much, Mr. Dipanshu. And now I welcome you all in the fourth webinar in the series of the Haryana Association of Surgeons of India. And I welcome Dr. Umesh Chhabra from the Agorha Medical College to moderate the session and to introduce the speakers. Dr. Umesh, please.
Thank you, Dr. Nivesh. So humble of you. Sir, I'm introducing my speakers, Dr. Nippun and Dr. Swapnil. So Dr. Nippun is a young and dynamic surgeon. He is keen to learn, and more importantly, he is keen to teach my boys with zeal and enthusiasm. He is currently assistant professor in Department of General Surgery in our institute and would be associate professor in a couple of months from now. He will deliver a talk on diabetic foot ulcers. Dr. Swapnil. Dr. Swapnil is an accomplished plastic surgeon and a pillar in Department of General Surgery in our institute. He will head the diabetic foot clinic, which is in pipeline and will be established in our institute soon. So both the speakers, welcome to you.
Thank you, sir.
Thank you, Dr. Umesh.
Thank you.
So, Dr. Nippun, please start your presentation.
Yes, sir.
Share your screen.
Yes, sir. Can I start, sir?
Yes, please start.
Good morning, sir. Good morning, everyone. Respected Dr. Gopal, sir. Respected Dr. A.R. Bansal. Respected Dr. Nivesh, sir. Respected Dr. Umesh, sir. And my co-speaker, Dr. Swapnil, sir. And all the senior faculty, senior surgeons of Haryana Association, of the Haryana Association. I am Dr. Nippun. I'm working as an assistant professor in Department of Surgery, Maharaja Agrasen Medical College, Agorha. So I would also like to thank JB Chemicals for giving this initiative for this webinars. As we know, this is the COVID time, and so academic it has taken a back seat. But these kind of talks will help us to unite again, and so that we can have a interactive sessions. And this is a very good time, I guess. Sunday noon, a good time for a discussion. We can meet each and every one of us. We can take the guidance from seniors and what we are doing from the senior surgeons. So I would like to start my topic today. The topic is diabetic foot ulcer overview. So as you all know, this is the most common problem, most common scenario which we get in our daily practice, especially in the medical colleges where we are working, especially in the referral centers like of ours or Dr. Nivesh's medical college. So these are at least on average, we get to see at least 4 to 5 cases of diabetic foot every day. Even in this COVID period, septic ward, we have around 15 patients right now at this present who are having diabetic foot and this kind of ulcers. So as means I've been into surgery from last 10 to 15 years, from my PG to now 10 years of my consultancy. So I would like to say, first impression when we get to see this case is foot amputation. That is the only thing we have practiced, and what our first thought is when we see this kind of patient. As I was given this topic, so I did research on it. I studied about this topic, and now my impression is 85% of the amputations which are done could be avoided. So this topic is not discussed generally. So this topic has to be discussed. The proper protocols has to be made. Then only we can prevent unnecessary. So I would like to starting with the how you define so foot of a diabetic patient with ulceration, infection, and or destruction of the deep tissues associated with neurological abnormalities and varying degrees of peripheral vascular of the lower limb. Any foot pathology that results from the diabetes or its long-term results, or what happens, it develops in the skin, muscles, bones of the foot as a result of nerve damage, poor circulation, and or infection that is associated with diabetes. So all this grouped together define our diabetic foot. So what are the important facts about it? So there is something called a rule of 15. So 15% of people develop an ulcer. Patient who are suffering from diabetes, 15% of ulcers will develop osteomyelitis, and 15% of the ulcers result in amputation. Then 85% of the amputation result from non-healing ulcer. Half of the amputated patient have contralateral amputations within 3 years, and half will die within 5 years. So every 22nd, a limb is lost due to diabetes. 1 million limb amputations occur yearly worldwide. In Indian scenario, 1 lakh legs are amputated every year with infected neuropathic foot, the most commonest cause of amputation. So diabetic foot is one of the most commonest cause of amputation in our Indian scenario. So up to 85% of the amputations can be avoided. However, there is a still gap between what's known about diabetic foot and what's really done to them. So this is a generally collection of the pictures, how the patient of a diabetic foot present. Mostly in the medical colleges, these all varieties of cases we see in our daily OPDs, in our wards. So this is just a different types of pictures, like every part of the foot can be involved, medial side, lateral side, sole, the plantar aspect, everything can be involved. 1 digit, 2 digits, all the 5 digits, non-healing ulcers, medial side, lateral side. So all the varieties, Charcot joints, everything, every picture you see, it is related to diabetic foot. And these are the mostly cases what we get to see in our daily practice, especially in tertiary care in medical colleges. So as you know, coming to the pathophysiology, diabetes mellitus, it is a polyneuropathy. It also involves the atherosclerosis, and ultimately it results in epidermal cutaneous ischemia, then insensible and deformed foot, and cold and pale foot due to the ischemia, which leads to neuropathic changes and neuroischemic changes, leading to gangrene, leading to infection, leading to ulcerations, and ultimately leading to non-healing, leading to callosities. These are the pathophysiology of the diabetic foot, how the foot at end happens, what the diabetes does to the foot. Mostly there is a formation of compartment syndrome in the foot. What happens, the compartment pressure becomes more than the capillary pressure, and there is the ascending infection, which leads a surgeon to prevent that ascending infection to do a amputation. So patient also come prepared for the amputation. But as you read about this topic, about this diabetic foot, so you will come to know how we can prevent the unnecessarily amputations. So generally IDSA, which is the International Diabetic Society, American Society Association, what they have formulated, what guidelines they have made is, before going for an amputation, you should at least give 4 months, that is 20 weeks of the management of the foot, so that you can prevent the amputation from the thorough debridement, VAC therapies, using different types of antimicrobial agents. So you should at least wait for 20 weeks or 4 months before deciding for an amputation. So generally our main aim is if you want to prevent ascending infection, so we generally advise the patient, and patient also come to us prepared, immediately go for amputation. Patient is also ready, amputation is done, and patient is discharged. So this practice has to be given a thought so that we can prevent unnecessarily amputations. We can prevent the morbidity of the patient. We can save the limb of the patient so that he can live the rest of his life, he can live normally. He don't have to feel a social stigma in the society. So that is why I'll be discussing about the different modalities, how to prevent the further infection, how we can prevent the unnecessarily amputations. So now coming to the risk factors in increasing diabetic foot ulcers, or the factors which increase the amputation risk. So one is previous amputation, previous history of diabetic foot ulcers, peripheral neuropathies, foot deformity, peripheral artery diseases, diabetic nephropathy, especially patients with end-stage renal diseases, patient having poor glycemic control, and cigarette smoking. Patient who are chronic smoker, they are more prone to develop diabetic foot ulcers. So what are the general or systemic contributing factors for developing a diabetic foot ulcer? Uncontrolled hyperglycemia. Number one point is uncontrolled hyperglycemia. Patient having uncontrolled hyperglycemia will definitely lead to a non-healing ulcer. So first thing is you have to control the diabetes the sugars level needs to be controlled. Duration of diabetes. If the patient is having long duration of diabetes and the compliance for taking anti-diabetic treatment is not good, patient will have all the problems. Peripheral vascular disease again add up to diabetic foot ulcers and amputations. Then the patient having symptoms of blindness or visual loss due to diabetic retinopathy, patient with chronic renal disease, patient with older age patients, they are also risk factors for ulceration. What are the local issues? Peripheral neuropathy, structural foot deformity, trauma, and improperly fitted shoes. As patient is a case of neuropathy, improperly fitted shoes will lead to as there are loss of sensations, patient will not feel any type of a chronic, the development of any ulcer, which will further lead to the chronic ulceration. Formation, history of prior ulcer amputation, prolonged elevated pressures, limited joint mobility. So for the foot examination, when you come to examination, there is a mnemonic. So D for deformity, look for any deformity, look for any infection, look for any pale granulation tissue, look for foul discharge, look for atrophic nails, then look for the breakdown of the skin, look for edema, see the temperature, compare with the other normal limb, look for the signs of ischemia, loss of hair, redness, brittle nails, look for the development of callosities, look for the skin color. So do the proper examination and take the proper history of diabetes, and then make the diagnosis diabetic foot, and then accordingly start or manage the patient. So there is one thing, 3-minute diabetic foot examination. So when the patient with a diabetic foot comes to you, so how will you examine the patient? In the history, in the OPD, what you need to ask about the previous leg or foot ulcers or lower limb amputation or any surgeries, any angioplasties, so that we can rule out ischemias, we can rule out peripheral vascular diseases. So any foot wound requiring more than 3 weeks to heal, any history of the wound previous which requires 3 weeks to heal, history of smoking, and what is the status of diabetes. If the patient is diabetic, what are the level of HbA1c, what is the level of what are the sugar levels in the last 1 month, whether the patient is on insulin, and what are the anti-diabetic medicines patient is taking. So does the patient have burning or tingling in legs, leg or foot pain with activity or at rest, changes in the skin color or skin lesions, loss of lower extremity sensation? Has the patient established regular podiatric care, whether the patient is seeing a podiatric consultant. So these are the things what you need to ask. Then come to the examination. In dermatological examination, does the patient have discolored, ingrown or elongated nails, signs of fungal infection? Look for discolored hypertrophic skin lesions, calluses or corns. Does the patient have open wounds or fissures? Does the patient have interdigital maceration? Then in the neurological examination, is the patient responsive to Ipswich touch test? This is the very OPD based test. In this test, what you need to do, ask the patient to lie down on a couch. You need to examine with a soft touch. You need to examine first, third, and fifth digit of each feet. So of each foot, you need to examine first, third, and fifth digit. If patient is not having sensation in more than 2 digits, that means this Ipswich touch test is positive, and patient is having the symptoms of neuropathy. So, and the patient is more prone to develop diabetic ulcer, the foot ulcer. Then coming to the musculoskeletal examination, does the patient have full range of motion of the joints? It is a multidisciplinary approach. So you need to involve another consultant. You need to involve the orthopedician, plastic surgeon, so that you can have a joint conversation about the patient management of the patient with diabetic foot. So send the patient to orthopedician, and so that, and ask him what about the movements of the joint, whether you are suspecting any osteomyelitis. So this needs to be done in musculoskeletal examination. Does the patient have obvious deformities? If yes, for how long? Is the midfoot hot, red, or inflamed? Then coming to the vascular examination, is the hair growth on the foot, dorsum or lower limb decreased? Are the dorsalis pedis and posterior tibial pulsation palpable? Is there temperature difference between the calves, feet, or between the left and right foot? Then there are recommendations for daily foot care. That was the clinical examination about the 3-minute examination and the history. Now coming to the recommendations for daily foot care. If you are suspecting a patient with diabetic neuropathy, and you know the patient is prone to develop ulcers, so you need to tell them that visual examination of the both feet need to be done, including soles and between toes. If the patient cannot do this, tell the family member to do it. Keep feet dry by regular changing of shoes and socks. Dry feet after baths or exercise. Report any new lesions, discoloration, or swelling to the healthcare professional. Then education regarding shoes. Educate the patient on the risk of walking barefoot even when indoors. Recommend appropriate footwear. Suggest yearly replacement of shoes. And then the overall health risk management. Recommend smoking cessation if the patient is a smoker, and recommend appropriate glycemic control. Then about the assessment part of the patient, when you're dealing with a patient with diabetic foot ulcer or a patient with diabetic with having neuropathy, so ask about the past history, ulceration, amputation, any history of Charcot joints, any history of vascular surgeries, angioplasties, what type of cigarette what is the status of his smoking, how many cigarettes he smokes per day, and neuropathic symptoms, both positive and negative symptoms, like positive symptoms like burning or shooting pain, sharp sensations, electrical sensations, negative symptoms, neuropathic like numbness, feeling of dead feet, vascular symptoms like claudication pain, rest pain, any non-healing ulcer, and other diabetic complications related to the diabetes like renal complications and any retinal complications. Then on inspection, dermatological, as we have discussed, look for the skin status, color, thickness, dryness, cracking, sweating, infection. Check between toes. Generally, when you check a patient of diabetic foot, interdigital, you will find kind of a slough. There will be a slough interdigitally. So that is mostly ignored. So that will further lead to non-healing ulcer or chronic ulcer. Look for the calluses, blistering, hemorrhage into the callus. Musculoskeletal examination, look for any deformity like claw toes, prominent metatarsal heads, Charcot joints, muscle wastings. Then coming to the neurological assessment. So assessment can be done with following methods. One is 10G monofilament test with this following test: vibration test, pinprick sensations, ankle reflexes, and vibration test. Then vascular assessment, foot pulses, ankle brachial pressure index. So dermatological assessment should include global inspection, presence of ulceration or abnormal arrhythmia, presence of callus, nail dystrophy, ingrowing toenail or paronychia, focal or global skin temperature difference between one foot and other may be predictive for either vascular disease, cellulitis associated with or without ulcer. Local skin temperature can be judged by back of the hand or by thermometers, laser thermometers. Musculoskeletal assessment includes evaluation of any gross foot deformity, like the figure A shows the hammer toe, the figure B shows the claw toe. Rigid deformities are defined as any contractures that cannot easily be manually reduced and are mostly frequently found in the digits. The other common forefoot deformities that are known to increase plantar pressure are associated with skin breakdown, which include hammer toe and the claw toe. These are the musculoskeletal deformities which we expect in the patients with diabetic foot. So about the Charcot arthropathy, it is defined as acute or subacute inflammation of all or part of the foot in people with diabetes, complicated by distal symmetrical neuropathy, accompanying fracture or dislocation that cannot be explained by recent trauma and with or without preceding surrounding skin ulceration. So how you diagnose Charcot arthropathy? It is diagnosed by a painless redness, swelling, and temperature more than 2 degrees skin temperature difference when compared with the contralateral foot. Dorsalis pedis pulses are often bounding. The patient is afebrile unless systemic infection is present. So by these symptoms, you can diagnose a Charcot's foot. So as how to assess the neurological how to do a neurological assessment. So there are different tests. I will be discussing about this test. One is nylon monofilament test, other is pinprick sensations, then are ankle reflexes, tunic fork test, and the vibration test. So peripheral neuropathy, most common cause of diabetic foot ulcer. As we all know, peripheral neuropathy is most common cause of diabetic foot ulcer. So all the patient coming with peripheral neuropathy, we have to do these tests so that we can come to a diagnosis. So clinical examination identifies loss of protective sensations rather than early neuropathy. So it is a simple test, requires no expensive equipment. 5 simple clinical tests are, as I've discussed before. So one or more abnormal tests would suggest this loss of protective sensations, while at least 2 normal tests rule out loss of protective sensations. So first is nylon monofilament test. So place a nylon filament perpendicular to the skin with pressure applied until monofilament buckles. So it should be held for less than 1 second and then release. Sensation of pressure should first be demonstrated to the patient on proximal site, like arm. The site of the foot may be then examined by asking the patient to respond to yes or no. Patient should recognize the perception of the pressure as well as identify the correct size. So this is how the nylon monofilament test is done. The second way to assess neuropathy is pinprick sensations. The inability of a subject to perceive pinprick sensation has been associated with increased risk of ulceration. A disposable pin should be applied just proximal to the toenail on the dorsal surface of the hallux with just enough pressure to deform the skin. Inability to perceive pinprick over either hallux would be regarded as an abnormal test. So ankle reflexes, absence of ankle reflexes has also been associated with increased risk of foot ulceration. Ankle reflexes can be tested with the patient either kneeling or resting on a couch or a table. Achilles tendon should be stressed until the ankle is in neutral position before striking it with the tender with the hammer. If a response is initially absent, the patient can be asked to hook the fingers together and pull. With the ankle reflexes then retested with the reinforcement. Total absence of ankle reflex either at rest or upon reinforcement is regarded as abnormal result. Then the other test is tunic fork test. Tunic fork of 128 Hz widely used in clinical practice and provides an easy and inexpensive test for vibratory sensation. Vibratory sensation should be tested over the tip of the great toe bilaterally. An abnormal response can be defined as when the patient loses vibratory sensation and the examiner still perceives it while holding the fork on the tip of the toe. So the result is positive. Then is vibration perception threshold testing, that is VPT testing. So there are biothesiometer it is also called neurothesiometer. It gives semi-quantitative assessment of vibration perception threshold. Vibration perception using the biothesiometer is also tested over the 6-point over the plantar surface. Stylus of the instrument is placed over the plantar point and the amplitude is increased until the patient can detect the vibration. The resulting number is known as the vibration perception threshold. A vibration perception threshold more than 15 vibration is regarded as abnormal, and higher this vibration perception threshold readings has been shown to be strongly predictive of subsequent foot ulceration. So if the reading of the VPT is more than 15, then the patient is prone to develop ulcerations. So then you can calculate the pressures. So peak plantar pressure, highest amount of pressure under the foot on a specific area at the forefoot in the diabetic polyneuropathy. Higher peak pressure, higher the risk of ulceration. Peak plantar pressures were significantly higher in patients that develop ulcer. The cut point was 87.5 Newton per centimeter square. So elevated peak plantar pressure is a risk factor for developing diabetic foot ulcers. So these were the neurological assessment. The second assessment of the patient is vascular assessment. So in the vascular assessment, so we history we have discussed. We have to ask the different points in the history. We have to look for changes in the skin, look for the pulses, compare it with the other normal foot, dorsalis pedis, posterior tibial, anterior tibial, and then popliteal and even femoral, compared with the other limb, which is normal. Then exercise testing, then achial branchial pressure index, duplex ultrasonography, and ultimately angiography, which will give the vascular assessment. So patient with diabetic, sometimes we get a patient who is having diabetic polyneuropathy and vascular symptoms. So chronic limb ischemia, the grading is grade 0 is mild claudication, grade 1 is moderate severe claudication without tissue loss or ischemic at rest pain. Critical ischemia, grade 2 ischemic at rest pain, and the grade 3 is tissue loss due to ischemic ulceration or gangrene. So if the AB, ankle brachial pressure index value, if it is less than 9, it is abnormal. 0.8 to 0.9 is mild peripheral artery disease. 0.5 to 0.8 moderate peripheral arterial disease. Less than 0.5 severe peripheral arterial disease, and less than 0.25 of ABI value is suggestive of very severe peripheral arterial disease. So these were the neurological assessment. Then we had vascular assessment, and now to rule out osteomyelitis. So most of the patient with diabetic foot, they have osteomyelitis, which is oftenly not diagnosed. We don't look at that angle. We never think that bone is involved. That is why we get that non-healing ulcers for so many days. We are doing regular debridements. We have tried VAC, but we have not looked the status of the bone. So this part should not be missed. Osteomyelitis has to be ruled out. Means whenever a patient of diabetic foot comes to us, I always tell my postgraduates to please take an orthopedic opinion, do the different x-rays, discuss with them so that osteomyelitis can be ruled out and we can save the limb, and we can do debridement, and we can discharge the patient with regular dressings. So sometimes we are doing dressing for 3 months, 4 months, but there is no sign of healing because we have not looked at this point of the bone, that is osteomyelitis. So osteomyelitis in diabetic foot occurs in about 60% of hospitalized patients, and with diabetic foot infections in up to 20% in outpatients with less severe infections. A definitive diagnosis requires both histological evidence of bone infection and isolation of bacteria pathogen from a bone sample. As bone biopsies are not routine in all clinical settings, diagnosis is made on the basis of clinical, laboratory, and radiological features. So probe to bone test, x-rays, blood test, CRP, ESR, more than 70 millimeter, that more than 70 millimeter of per hour increases the likelihood of osteomyelitis. Then there is one more test, that is PCT, procalcitonin levels. And if all these three are raised, then definitely patient is having osteomyelitis. As PTC, as these two tests are readily available everywhere, so I would like to recommend that CRP and ESR should be done in all the patients having diabetic foot ulcer, so that we can rule out osteomyelitis. This is the simplest test. If the ESR is more than 70, then mostly the patient is having osteomyelitis. If the patient of diabetic foot having ESR more than 70, mostly the patient is having osteomyelitis. And normal X-ray of the foot, okay, and discussion with the orthopedician. And if you are not, if you have done all this test and then also wound is not healing, then we can do further studies like MRI, or we can do PET scan and CT scan to rule out if there is any other bone abnormalities, or there is some sort of malignancy which is developing in non-healing ulcers. So risk classification based on the comprehensive foot examination. So risk category 0, no loss of protective session, no peripheral artery disease, no deformity. Treatment recommendation is patient education, including advice on appropriate footwear. When the patient is having loss of protective sensations and a deformity, it is risk category graded as 1. Consider prescriptive or accommodative footwear. Consider prophylactic surgery. If deformity is not able to be safely accommodated in the shoes, continue patient education. Risk category 2 means patient having peripheral artery disease plus or minus loss of protective sensations. Consider prescriptive or accommodative footwear. Consider vascular consultation for combined follow-up. And third is history of ulcer or amputation graded at 3. That treatment is as category 1, and consider vascular consultation for combined follow-up if peripheral artery disease is present. So risk classification, a risk classification system which allows for efficient classification of persons with diabetic foot ulcers and guides clinician in selecting appropriate therapeutic intervention, activity, recommendation, and follow-up. So very low risk category score is 0 to 6. Clinical indications, no loss of protective sensation, no peripheral artery disease. Recommend professional follow-up every 12 months. So annually, patient needs to see a doctor. Low risk category score is 7 to 12. Loss of protective sensation plus minus non-changing foot deformity. Patient needs to see the doctor for every 4 to 6 months. So intermediate risk 2 and B, score 13 to 19, peripheral artery disease and or deformity, loss of protective sensation, every 3 months visit is required in a diabetic foot clinic. So 3 and 3B, 20 to 25 score, presence of diabetes with previous history of ulceration and amputation, every 1 to 3 months diabetic foot clinic patient needs to visit. So urgent risk to 20 to 25 score, open ulcer is present, active Charcot foot, arterial compromise, immediate referral and consultant. Patient need to see diabetic foot consultant. So these are the, there is one mnemonic, that is be smart to prevent the ulceration. Beware of risk factors, educate the patient and health providers, structured clinical assessment, metabolic evaluation and management, assessment of risk, and as you know, it is a multidisciplinary approach. It requires a team, plastic surgeon, orthopedician, vascular surgeons, general surgeons, referral surgeons. So everybody needs to be educated about the diabetic foot. So wound prevention and management cycle, assess and reassess. Assess the patient, the wound, as well as environmental and systemic challenges. Identify the risk and causative factors that may impact the skin integrity and wound healing. Set goals. Prevent, how we can prevent the diabetic foot ulceration. Whether the ulcer, if you're getting ulcer, whether it is a healing, non-healing or non-healable. Quality of life and symptom control. How can we improve the quality of life of the patient suffering from diabetic foot? Assemble the team. Select a membership based on the patient need. Establish and implement a plan of care. Like environment and system, patient, wound care. Ensure meaningful communication among all the team members. Ensure consistent and sustainable implementation of the plan of care, like cleaning and debridement, bacterial balance, rule out and treat superficial infection, moisture balancing, like look for the dressings which control the moisture, then evaluate outcomes. whether the goals which were set in the team are met, ensures sustainability, and then the cycle is completed. Goals partially met or not met, reassess. So the main aim to manage this diabetic fit should be assessment and reassessment. Assess, do the follow all the protocols and look at whether you have healed the ulcer, whether the patient is fine, everything diabetic is controlled, patient is or the wound is showing a healing, or it has gone into the callus formation or non-healing. Then reassess, make another goals. And this is how the cycle, the teamwork in management of diabetic foot care, management of diabetic foot needs to be implemented. So 5 cornerstone of the management of diabetic foot. The situation can be changed and possibly reduce amputation rates between 50 to 80% by 50 to 85% by regular inspection and examination of the foot and the patient education, identification of the foot risk, education of the patient, family and healthcare providers, appropriate footwear, multidisciplinary approach and treatment of ulcerative and non-ulcer pathologies. So lifestyle modification, control of the blood pressure, lipid management, glycemic control, smoking cessation. These are the lifestyle modifications which we can do. So what should be our goals? So aim for glucose control target of 7% or less. Blood pressure aim is should be 130 to 80. Cholesterol aim for LDL target of 2 millimole per liter or less. Drugs protect against heart attack and stroke with appropriate medication. Exercise, participate in regular physical activity. Foot care, perform a daily examination, and smoking cessation and stress management. So nail and skin care, examine of diabetic fit on daily basis. Nail should be washed and dried at least once a day. We should make sure the patient who are diabetic having the polyneuropathic findings. So they should not be using heating pads. They should not use the water for rinsing, which is more than 37 degrees Celsius. They should be instructed to use footwear indoor as well as outdoors. Observe and physical examine inside the patient shoes on a daily basis. If the patient cannot do, a family member has to do it. Recommended change and put on a clean socks on daily basis. Discourage wearing of tight sock, not to use any kind of chemical substance or commercial pads or plaster in order to treat the calluses or the feet. So admitted patients, what are the changing patterns? Now we see a biofilm. So biofilm on the ulcer is the colonies of the microorganisms. Okay, diabetic foot osteomyelitis, compartment syndrome, ischemic foot, Charcot foot. So biofilm is a major concern in healing chronic wounds. So 4 in 5 chronic wounds contain biofilm. Biofilm is actually it is the colony of microorganism which get adhered to the wound, which is not, and it is not often identified, which result in ineffective treatment. So something about this biofilm, the life cycle of a biofilm consists of several events occurring in the following time frame. If the bacteria, the colony of the bacteria is adhered to a surface, it is reversible. Attached bacteria divide and begin to excrete extracellular matrix within seconds to minutes. The matrix cell mixture expand from architectural features of the biofilms in minutes to hours. Further expansion and microbial growth within days, and dispersions of planktonic bacteria days to week. This is how the biofilm progresses. So some pictures, this shows the dirty wounds, definitely high microbial, polymicrobial infection. So our main aim is to prevent the progression of the biofilm. So now coming to the management. So the mainstay of the management of diabetic foot is it has been a debridement. So the debridement can be scalped with a knife, with our normal scalpel, or which can be done on the bedside after giving local anesthesia or even in the spinal anesthesia. Then you can use a dermal curate or the ultrasonic devices. These are the different methods of debridement, and the debridement should be extensive. The initial debridement should be extensive so that we can remove the entire the slough, and we should we can give the proper base for the development of a pink and healthy granulation tissue. So until now, unless this slough is removed, until or unless bacterial count is reduced, the patient will not show any intention, the ulcer will not show any intention of healing. So debridement has always been the mainstay of the treatment of the bad diabetic foot ulcers. Then the other methods, as we know, is very common these days, is VAC, that is negative pressure therapy. So it has a significantly higher rate of granulation tissue formation after 4 to 5 days of treatment. Bacterial counts in the human wound tissue treated with VAC technique have demonstrated significant decreases after 3 to 4 days. But it is expensive and it is patient cannot afford. So that is the limitations of this VAC therapy. So then now recently, when you read, the new concept has come, so biofilm based wound care. So selective biocides like cadopsomar, iodine, silver, hydrophera blue, these are the different type of biocides. So when you read the IDSA guidelines, so there are guidelines in 2012. In 2012, so this they were not giving much importance to cadopsomar, iodine, or the silver or hydrophera blue. Now in last 8 years, when they have reviewed more than 1800 papers, so they have come to the conclusion that these antimicrobial agents, they can help in preventing the biofilm to mature. So this is just a change in the trend which we have experience in this diabetic foot care. So anti-biofilm agents like lactoferrin, xylitol, farnesol, surfactants like polaxamar, and fatty acid gel. So something about this cadopsomar iodine, it is a polaxamar which cleans wound and break biofilm, and cadopsomar absorb, exudate, and prevents biofilm formation, and the iodine component in it, which is a antimicrobial. So the 4 key product attributes of this is, it is a sustained release iodine, okay, and with the minimum toxicity, it absorbs, exudates, and biofilm disruption, and it prevents reformation. So what are the recommendations of the dosage? It should cover the entire wound surface for depth of 3 millimeter. Single application should not exceed more than 50 gram. Total amount of ointment used in 1 week should not exceed 150 gram. Duration of treatment should not exceed 3 months in any single course of treatment. So 10 commandments of foot care in diabetes are: do not walk barefoot, inspect the feet daily for blisters, wound, bleeding, warmth, do not apply hot fermentation, cold packs, or strong ointments, use correct footwear, do not walk bearing weight on affected foot, do not sit cross-legged or long time, leads to ischemia, do not remove footwear during travel, cut the nails regularly, square them, trim them squarely, do not cut corns, calluses with blades or knife, potential to form an ulcer, clean the feet twice a day with soap and water, wipe web spaces dry, and apply softening gel. These are the 10 commandments in the foot care. So I'd like to end my talk. Thank you very much, Dr. Umesh sir. The questions will be taken, I think, after Dr. Swapnil sir finishes his talk. So Umesh sir, back to you.
Thank you. Nivesh sir.
Thank you, Dr. Nippun. Please stop your slide sharing.
Yes, sir.
And very nice presentation. And we'll take the questions in the chat box after the presentation of Dr. Swapnil.
Yeah,
so I request Dr. Umesh to please request Dr. Swapnil to present the his presentation.
Sure, sir. Dr. Swapnil, sir, you are listening to me?
Dr. Swapnil, unmute your mic.
Yeah, I have done the unmute. Yeah.
Yes, sir.
Are
Yes,
you
sir.
hearing now?
Sir?
Yeah, I'm hearing.
Okay, sir. Sir, kindly start your talk, please.
So share your slide, sir.
Yeah, very good afternoon to everyone. And
Good
first of
afternoon.
all, I would like to thanks to Dr. Gopal and Dr. Nivesh for giving me the opportunity to present my work on this surgical management of diabetic foot. And if we say the natural history of the diabetic foot disease, the diabetic foot ulcers follows a predictable progression from the callus to gangrene. First of all, any in patient of a diabetes, any pressure over the foot will start with as a callus. It is a thickening of the skin. That will lead unrelieved pressure will may lead to the ulcer formation, superimposed with the infection that can lead to gangrene. And finally, the outcome, either it may be salvageable or it may be the end in the amputation. There are the three major factors which play a dominant role in the causation of these diabetic ulcers. Either first is the neuropathy of the diabetic affects the motor, sensory, and the autonomic nerves. And second is the limited joint mobility, and third one is the ischemia. These are the three major culprits which leads in the pathology of this diabetic foot ulcer. How this formation of callus occurs basically? What happens when the motor neuropathy, it causes the muscle atrophy of the intrinsic muscles as lumbricus and trochei. It results into the deformities. As well as sensory neuropathy results in the loss of protective sensation, which leads to the repetitive trauma of the which patient is not aware of. And along with this autonomic neuropathy, this causes the imbalances in the blood flow. And this picture is showing basically deformities due to the neuropathy. It may lead to the high arched foot with the prominences over the head of the first metatarsals all the way. You get the prominences over the heel region. And in second picture, you can see the prominences of the corresponding calluses, which leads to the due to pressure. Now this callus can lead to the pre-ulceration because there is limited joint mobility combined with shear forces that result in the formation of callus. They result in increased focal pressure by about 26%. If this persistent high pressure underneath these callus lead to breakdown of the underlying skin and soft tissues, resulting in the subcallus ulcer. These are the pictures showing first in callosities, and you can see the subcallus
Hello.
ulcer. Hello? Yes? Any problem?
No, sir, no. So
No, sir,
continue.
please continue. Continue,
Okay,
sir.
okay. So now why these do ulcers recur? Because most of the patients have taken the treatment for ulceration and that can be cured. But sometimes after they again recur. Why it is so? Because there is a persistence of the sensory loss. Because once this sensory loss is continuing, it can't be reversed. You can't do much in the late cases of neuropathies. And second one is the persistence of uncorrected biomechanical defects. They can be corrected They can be corrected either by internal offloading or external offloading. We have to divide it, what are the staging of the diabetic foot ulcer. There are so many classifications described in the literature, just as a Magid-Wagner classification. Second one is the University of Texas staging. In that, 16 possible stages were described, but very helpful in the daily use to practice is a Ganga Hospital classification, treatment oriented staging basically. The Ganga Hospital is situated in the Coimbatore, and they stage these patients into the 4 class. First class, the foot at risk basically. You can see the foot at risk, and these pictures showing the foot with the callus. There is no ulceration. The pulses are, peripheral pulses are present. There are no skin change otherwise. Second one, class 2 is ulcerated foot. You can see the ulcerations over the plantar area along with these callosities, but still the vascularity is normal. Any one of pulse is present in these cases. Third one is the crippled foot. They are the complicated grade 2 ulcers with invasive infections, which are evidenced by the swelling, erythema, either maybe blood formation, or the same second picture is the same foot after debridement, which shows the extent of soft tissue loss due to the infection. And the fourth class is critical foot, in which there are the extensive transmural infection, which complicate this grade 2 ulcer, causing soft tissue gangrene on the plantar as well as dorsal aspect, which can lead to a systemic sepsis. And the patient underwent a below-knee amputation of this one. Now coming to the management part, depending upon this staging, there the three cardinal principles of management. One is the appropriate and timely removal of calluses. Second one is the control of infection. And third one is the reduction of weight-bearing forces. The interventions basically which we do in these diabetic foot patients. First is the preventive podiatry, which you can say the conservative management basically. And second thing is the surgical offloading. Third one is the debridement and reconstructive surgery. Or fourth one may be the major amputations. And the treatment stage is basically depending upon the what is the staging or the class of the diabetic foot patient. First class 1, which is the foot at risk, they can be managed only by the preventive podiatry, just like conservative treatments. Second class ulcerated foot, they can be managed by the surgical offloading or internal offloading. Third one is the crippled foot, that can be debrided and done by wound coverage by the either grafting or the flaps or something else. And fourth class is the critical foot, in which the salvageable foot is not salvageable, and in that case we have to do major amputations. Now this is the pedobarogram, which shows the peak pressure profile for a diabetic foot patients. It is a first picture is showing the two-dimensional depiction of the plantar pressure. You can see the maximum pressure is over the either the head of the metatarsal region or at the heel area. There is a maximum pressure. And second one is a 3D depiction of plantar pressure. The abnormal spikes along the lateral forefoot area. The preventive podiatry for the class 1 group of patients is basically nothing else, just we can debride the callus, we can do the proper nail care, and there are some offloading devices which are available or customized footwear for so that patient will not develop any ulceration. Second thing is the offloading. Offloading is basically what is offloading? It is a measure to eliminate abnormal pressure points to promote healing or prevent recurrences of diabetic foot ulcers. And this offloading is basically, one is external and second is internal. Then external offloading is basically the gold standard is total contact cast. The patient is given basically a cast which is in contact with the skin along with the whole sole plantar area. And but this is very cumbersome to give the patient to manage because the wound is undersaid. So second is one is a removable cast walkers. The patient can walk on this cast. And third one, we can give customer therapeutic footwears. So they can prevent the ulceration formation in the group 1, class 1 patients. And second method of offloading is basically internal offloading or surgical methods. The surgical offloading is basically depending upon the staging or the class or the level of the ulceration basically. The first thing in surgical offloading is Achilles tendon lengthening. Basically, mean 28% reduction in peak pressure on plantar aspect of forefoot. It follows the percutaneous Achilles tendon lengthening in diabetic patient who are at high risk of ulceration. So we have to look for whether there is a tight Achilles tendon. Second one is the surgical correction of skeletal abnormalities depending upon the location of ulcers. They are whether the ulcer is location of great toe or minor toes, forefoot ulceration, midfoot, all the surgeries are depending upon the site of ulcerations. And third is the plantar pad augmentation. Sometimes there is a loss of fat of pad or the plantar surface. This can lead to increased pressure. So we can augment this fat pad by the fat injections or we can by the fillers. So depending upon the location of ulcer, first is the grade 2 ulcers. This grade 2 ulcer accounts almost about 1/3 of the ulcers in the diabetic foot. Mostly the location, either it is over the IP joint over or there is subangular tip ulcer basically. This pathogenesis for this ulcer is related to the stiffness of first metatarsophalangeal joint. So it is basically, so we have to release the stiffness of this metatarsophalangeal joint. This is the ulcer which is planted to the IP joint. So because you can see in the picture this intrinsic tendons or the lumbricals, it is inserting into the head of the proximal part of the proximal phalanx, and it becomes basically disease. So normally what this intrinsic muscle do, it basically cause the flexion of the tarso-metatarsal joint. But when it is lost, so this interphalangeal joints become the flexed position and it will the pressure. So for this, we give this do the callus arthroplasty. In this callus arthroplasty, we remove the proximal part of the proximal phalanx along with this common intrinsic insertion of tendon, which remove this pressure. In proximal, in great toe ulcers, there are selective plantar fascia release we do sometimes. Because this plantar helix interphalangeal joint ulcer are best treated when we restore the mobility of metatarsophalangeal joint. So sometimes we do the selective transition of this plantar fascia, which is going to the great toe, and it release the functional helix. This is the same callar excision arthroplasty which you used to do. It is the whole depiction. In first picture, plantar phalanx interphalangeal joint ulcer is showing. Second, we open it from dorsally. We remove over the metatarsophalangeal joint and excise the proximal part of this proximal phalanx along with this muscle which is inserting over it. It results in slightly shortening of this digit, but it becomes mobile. And lower one, you can see the X-rays of the pre and post-operative. Then comes to the ulcers of the minor toes, basically. Ulcers of minor toes are usually associated with claw and mallet deformities. The toe which occur due to the intrinsic paralysis, because due to the motor neuropathy. The clinical effect of motor neuropathy is basically intrinsic muscle atrophy, and it is intrinsic minus foot, because the intrinsic muscles is not working, and they lead to the flexion of interphalangeal joint with the hyperextension of metatarsophalangeal joint. So you can see in the picture both the deformities. Only a small percutaneous flexor tenotomies can be useful in cases of these diabetic claw foot over the ulcer of tip. Because as you see the claw tip, it is a basically metatarsophalangeal joint hyperextension with PIP and DIP flexion require the functional restoration of tendon transfer, such as girdle stone tailor transfer to correct the deformity. In this, the extensor hood transfer with Z lengthening of the extensor over the claw toe correction. So over every toe, we have to correct it. Second one is a mallet toe correction. For the mallet toe correction only, we have to just do the flexor digitorum longus tendon stenotomy, because once we do the cut the tendon, this flexor, it will become into the extensor, so it will correct it. Now there are some plantar forefoot ulcers. They are also very common. These ulcers located on the metatarsal heads, starting from the first metatarsal to the last metatarsal. This basically most commonly occur due to the tight tendoachilles contracture, tight tendoachilles tendon contracture, because it leads to the ankylina equinus, and it all the pathomechanics become. So this plantar surface showing first metatarsal head, then we remove this extensor hallucis longus tendon transfer to the first metatarsal, which lead to the correction of this pathomechanics, and then ulcer becomes healed without doing anything. Or in the cases where the transfer, this tendon is tight, tendoachilles is tight, that can be relieved either by TA lengthening, or we can do gastrosoleus resection. This gastrosoleus resection can be done at the level of the junction of gastrocnemius and the soleus muscle, basically. It is known as gastrocnemius slide. Then comes to the ulcers over the plantar midfoot. The ulcers of midfoot are usually associated with structural disorganization of midfoot secondary to the Charcot neuropathic osteoarthropathy, which is progressive non-infectious destruction of bone and joints. Midfoot bony prominences in foot with stage 3 consolidated Charcot's arthropathy, which has become the collapsed. So we have to do the osteotomy at the points which are level, and after the excision of prominence is showing in second X-ray. And the treatment of these ulcers basically depend upon the staging of the Charcot's osteoarthropathy. And there are basically 3 stages of this Charcot's osteoarthropathy. One is the acute development fragmentation, second subacute, and third one is the chronic. Depending upon this presentation, there is a different methods of the treating of these Charcot's osteoarthropathy. And then comes to the ulcer over the hind foot. These hind foot ulcers are related closely because of the insufficiency of gastrocnemius soleus complex. such as forefoot ulcers are related to its contracture. These are related to the absence of this gastrocnemius soleus complex. So cause of this tendo Achilles deficiency must be ascertained, as its correction is imperative for the maintenance of well-healed hind foot. So tendo Achilles repair by suture anchor with flexor hallucis longus augmentation. This divided tendo Achilles with gap and no distal stump. So flexor hallucis longus is transferred through the calcaneum to provide a new insertion, and the repair is completed with flexor hallucis longus weaved into the lengthened proximal tendo Achilles system. Now coming to the ulcers over the dorsal part, mostly these ulcers are because of the infection. There is no pressure problem. So these are treated by the conventional debridement and the wound coverage by the skin grafting. Now there are some ulcers due to only ischemia. A dysvascular foot is defined as a foot without palpable pedal pulses, or a documented ankle brachial pressure index is less than 0.9 or more than 1.3. This macrovascular vascular disease of lower limb in diabetes affects the major arteries. Its management depends on the location of block and requires the involvement of vascular specialists. In general, suprapopliteal disease respond well to endovascular therapy, while infrapopliteal vaso-occlusive disease has improved long-term patency along with the open surgery by the bypass surgery. Nerve surgery. Early, because these patients have the peripheral neuropathy. If the patient is having early diabetic neuropathy or patient with the compression neuropathy, they will be only benefited. In the late stage of the peripheral neuropathy, they will not be benefited. And this compression can be clinically detected by the tinel signs over the site of compression. And the common sites are basically posterior tibial nerve in tarsal tunnel, anterior tibial nerve at the dorsum of foot, and the common peroneal nerve around the fibular neck. Now the class 4 patient, which is having the critical foot, and because in this ischemic gangrene with the loss of critical structures and functional reconstruction is not possible, and the salvage is not possible, or the importance of the recognition of the stage 4, because what do we need to recognize, why we have to need, because it is a threat to life, and if we going for a salvage, it is a futile. So we have to recognize this stage 4. And what are the major quick decision? That is a minimize the wastage of our resources and improve the patient's quality of residual life. So what is the need of the hour after going this? The first is the early surgical intervention. It helps because previously we used to do keeps on going dressing and dressing of the all the ulcer irrespective of site. So it is the early surgical intervention. And what surgery it is depends what type of surgery and what stage, and when to stop with the attempts of salvage. It is only 2 things which we have to keep in mind. So final approach for the diabetic foot, if suppose foot in a class 1 category foot at risk, we will go with the preventive podiatry. Second, class 2 level of ulcers, that is ulcerated foot, it will be treated by the surgical offloading as per the location of ulcer. Class 3 diabetic foot is with crippled foot, that will be managed by debridement or the reconstructive surgery. And class 4 diabetic foot, that is a critical or the gangrenous foot, that will be dealt by the major amputation. Thank you.
Thank you so much, Dr. Swapnil. And I request Dr. Umesh to ask the questions from the participants to our esteemed speakers.
Sure, sir, sure. Before I start the questioning, I would like to say that both the presentations were complementary as well as supplementary to each other. Very good presentation, sir. Nice.
Very nice. Nice.
The question is from Dr. Utkarsh. He asked, can cadoxomer be used in hyperthyroid patients? If yes, what should be the dosage?
As it is
Any of you can take it.
as it is a topical ointment, I don't think so there are any guidelines for this. The recommended dose is less than 10 milligram per day for 3 millimeter of depth. So that is the only thing. And with any, I don't think so it has any disadvantage in patient who are hyperthyroidism, because it is locally, it is applied. I need to read more about it. Right now, I don't think so there is any drug interaction with the cadomer, as it is topical only.
Well, that is the apt answer. All should go through it, the literature, whether it should be used or not.
I want to add one thing. In some patients,
sir.
it has been seen that it can cause the hyperthyroidism in the hyperthyroid patients. In very little case report has been there. So when we in the hyperthyroid patient, we should be use it as with a caution, and also we have to take care repeatedly. We get the thyroid function test done in the patient where hyperthyroidism can occur.
Okay.
Thank you, sir. Thanks for enlightenment. Another question from my side is, already it has been taken care of in both of your talks, but still to take away at home message, which is the most important factor or factors that should be looked for in a patient of diabetic foot to save the limb in later course, because we know it's a chronic disease.
Mostly, sir, first is the thorough assessment. Start
Am I
with
audible?
Yes, sir. I'd like to answer it. First is thorough assessment. Start with the history, neurological examination, vascular examination. Don't miss out osteomyelitis and don't jump into amputation. IDSA says you should at least give a trial before amputation for 20 weeks, that is 4 months. So proper assessment, multidisciplinary approach, involvement of the plastic surgeons, vascular surgeons, orthopedician. This team means a multidisciplinary approach to a diabetic foot ulcer. It can save the limb. So don't like what is our means whenever we see such kind of patients. So our reaction is do the amputation. So IDSA says at least 20 weeks should be given for the treatment. So like if you're and for like systemic antibiotics, for 1 week you give systemic antibiotics, then switch on to oral antibiotics. Do the bone biopsies to rule out osteomyelitis. Do CRP, PCT, and ESR. Do the X-rays. Discuss with orthopedicians. Rule out. Do the bone biopsies to look for the microorganism which is growing if the ulcer is not healing. So these things need to be done first to salvage the limb, and then ultimately, if we have done all these things, we have approached the diabetic foot by a stepwise. Then also we are not getting any results. Then last resort is amputation.
Thank you. Thank you, Dr. Nippun. I would like to add something to it.
Yes, sir.
Early intervention is the key word. Early intervention is the key word.
Yes, sir.
When you are dealing with diabetic foot ulcers or diabetic foot, be it neuropathic or be it other things. And now you were talking about multidisciplinary approach. I want to know that, as we all know, to treat or salvage a diabetic limb, a multidisciplinary approach is required. Who, according to you, should be included in a diabetic foot clinic as a team member? There should be an hierarchy.
First, sir, the patient will come to general surgeon first. Then you need help of a plastic surgeon, vascular surgeon, orthopedician. These are the team members. Psychologist.
Yeah, I have interrupted. I am interrupted. May I say? May I give the answer?
Yeah, sure, sir, sure.
Yeah.
Why not?
The patient will never come directly to the surgeon, because patient is having diabetes mellitus, and first he will go to the physician. Physician will be his primary doctor. Only he will tell him to look after their feet for the preventive aspect for the diabetic foot ulcers. So once or where there is the earliest sign of this diabetic foot ulceration or formation, either as a callosities, then he will ask him to visit a surgeon. Then surgeon will assess. So first is the physician or endocrinologist, then a surgeon come into the picture. Surgeon will assess what is the staging, what is the of this ulceration, there is class 1 or class 2. If it requires any bony, there is ulceration, then we can involve the other members, either a plastic surgeon or a vascular surgeon for the basically ischemia purposes, or any orthopedician if there is an osteomyelitis that Dr. Nippun is or there are physiotherapists basically. They can be involved because orthosis, prosthesis, which give the correct prosthesis for the preventive basically.
Right, sir.
First, second, along with these, if you say this is for the surgical sites, for the medical side, other member may be a dietitian, very important member.
Right, very good, sir.
So these are the some few members which can be a team for the diabetic clinic, basically.
Thank you, sir. This is the plight of the doctors sitting at tertiary center, that the patient reaches to us at such a stage that we have no choice other than to amputate the patient. We were meant to be good healers, but we are now excellent amputators now.
Yeah, I agree.
It was a good, good talk, sir. Dr. Nivesh, I extend my thanks to you for such a good platform provided by you.
Dr. Umesh, I want to add one more thing, because you say as we are on a tertiary center, and most of the patients which come to us in our clinics, they are mostly 80 to 90% in class 3 or class 4.
Right, sir.
And we don't have any much to do to save the limb, or either we have to do the amputation. Because one thing is, as in class 2, when there is ulceration, either we can go for the offloading, surgical offloading things. But most of the time, these are not being happened in normally. So we are doing just dressings only. And for dressings, I want to highlight one thing. Dressing in povidone iodine is synonymous.
Right.
Everyone is doing dressing, that is povidone iodine only.
Betadine.
Betadine is dressing. Dressing is betadine. It is, you have to evaluate the wound. Every wound has to be evaluated. And it is not betadine which is to be treated every wound. Every wound is different. What it will vary, there is a slab, whether there is a granulation healthy, unhealthy, or there are the different varieties to the dressing. Dressing it itself is a big chapter basically. Yes. But 99% this dressing is done by a betadine only. That is the main culprit over this diabetic foot mismanagement.
Sure. Bilkul theek bol rahe ho, sir.
Dr. Swapnil, I want to ask one thing. At what time in the management of diabetic foot should the plastic surgeon intervene? At the initial stage, or at the what stage you feel should be an intervention of the plastic surgeon?
At the initial stage, I must say, suppose when if patient is having ulceration over, if there is any ulceration over the foot, or you can say the class 2 defined by, so at that ulceration, you have to involve the plastic surgeon at that stage, because you have to assess whether there is because there must be joint immobilities, there must be pressure points. So you have to do offloading surgeries. They are the preventive offloading surgery to stop the recurrences. As the Dr. Umesh was asking, how we can save him for a long time, he will not recur. So at that stage, you must involve, definitely.
And I think it basically it's a part of medicine, surgery, and the orthopedician to start it, because any 3 patient initially comes, and with their combined management, then dietitian, plastic surgeon, vascular surgeon, and neurosurgeon as required can be involved.
Psychologist also.
Exactly, sir. Exactly.
So with this, there are no more questions. I thank all the speakers for the excellent presentation and for the quenching the queries of our participants. Dr. Umesh, for the your super marvelous, sir, your moderation.
Thank you, sir.
I thank our president, Dr. Gopal Singhal, for giving us opportunity to continue this webinar. Now I request Mr. Chand Khan from the JB Pharmaceuticals to say a few words on whose they are providing us the base on which we are performing the presentation.
Welcome.
Also, thank you. Thanks very much. Thank you, ASI Haryana chapter, for giving us opportunity for providing this platform to you, sir. It's our honor to serve for you, sir. And as rightly said by the Dr. Nippun, as well as, and at the same time, it fits in the time model which you have studied in your college days, sir. Tissue debridement, infection control, moisture balance, and edge margin response, sir. And second product which we offer, sir, that is Metrogel M. That is a combination of Miprocin plus metronidazole. Miprocin itself has a broad spectrum. By adding metronidazole, you can further enhance the performance, sir. So Dr. Nippun as well as Dr. Swapnil has a very good experience with the cadexemar iodine. Thanks for these. And with this, I thank you. I thanks Dr. Nivesh, Dr. Gopal Singhal for considering us for providing this platform. Sir. Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you,
Thank
sir.
you, Dipanshu and Johnny.
Thank you, Dipanshu. Sir, control आप ही के पास है, sir.